Good afternoon, everybody. So we'll start with our clinical symposium about diabetes advances. So we have 3 eminent speakers. So we'll start with our first speaker. It's my pleasure to invite Dr. Ebtihal Alyusuf. She's a consultant endocrinologist with special interest in diabetes and diabetes technology. She completed her adult endocrinology fellowship at King Saud University Medical City, and she's certified by the Saudi Commission for Health Specialty Commission. So, Dr. Ebtihal, floor of yours.
Thank you, Dr. Sumaya, for the nice introduction. I will be talking about in the time range in the upcoming 20 minutes and how it is a complementary glycemic metric to the hemoglobin A1c, to the non-standard of care hemoglobin A1c in review or for the testing of the glycemic control. So I don't have any disclosure. So this is my outline. I'll be talking about the tight glycemic control evidence, the traditional methods of glucose monitoring and their limitations, and I will focus about CGM and the time and range and their clinical impacts. So everybody we know from the DCCT trial and the UK PDS trial, how is the tight glycemic control affect and decrease the reduce the incidence of microvascular complication in patients with type 1 and type 2 diabetes. To reach tight glycemic control, glucose monitoring is a cornerstone in treating diabetes. What are the benefits of glycemic monitoring? It is useful for diabetes self-management. It is useful to optimize medication and adjust medication. It gives information about the response to meals and lifestyle. It could be a safety measure to avoid hypoglycemia and prevent long-term complications. So the traditional key tools for assessing glycemia is the self-monitoring of blood glucose, SMBG, hemoglobin A1c, and the new metric which is the time and range by CGM. So SMBG, where we measure glucose capillary finger stick measurement, which provides point-in-time glucose values and help guides insulin dosing and self-management, but it has some limitations. One of the limitations that SMBG is affected by multiple factors and conditions. Substances like the high and the low hematocrit affect the accuracy of SMBG and, for example, vitamin C, acetaminophen. The ADA recommends checking SMBG up to 6 to 10 times for people with diabetes who are using insulin. Also, the more the frequent the SMBG, the better the A1C. However, it is difficult for our patients to do it, non-convenient. Usually, patients will not do it as you see in your daily clinics. Also, some patients will put the numbers just before their appointments, non-real numbers. And also, you will not be able to capture the real stories by the SMBG. About hemoglobin A1c, which is the traditional gold standard, it is the key parameter in glycemic control assessment. It gives us a clue about the average glucose over the 2 to 3 months. It's a key surrogate marker and a strong predictor of development of long-term complications, and it's being used in the trial as an outcome measure, but it has also limitations. So the HbA1c is important. We diagnose diabetes by the ADA criteria guidelines by the level of hemoglobin A1c. It is available, affordable, easy to test. It gives you a clue that it is a call to action, but it doesn't tell you what action you can do. The A1C drive average glucose study give us the evidence about how the A1C correlate well with the average glucose. So if a patient with hemoglobin A1C of 7%, this correlates with an average glucose of 154. As you increase the A1C by 1, you increase the average glucose by around 30 milligram per deciliter. However, A1C has some limitations because it is an indirect marker of glycemia, reflects the glucose bound to the hemoglobin. It gives us an average, not a daily glucose behavior. It gives us a single snapshot, but it doesn't capture the glycemic variability and patterns. It is insensitive to hypoglycemia. You will not know about the hypoglycemia in a patient with HbA1c of 6 or 7. And there are a lot of factors that interfere with the accuracy of A1C, like hemoglobinopathies, chronic kidney disease, and it will tell you you need an action, but it doesn't tell you what action is the best for the patient, and it doesn't explain why the patient is controlled or not. These are some of the conditions and medications that affect the accuracy of hemoglobin A1C, giving you inappropriately high or low hemoglobin A1C. So, because of the limitations of hemoglobin A1C and SMBG, this highlights the gaps in diabetes care and the need for a complementary matrix. CGM overcomes the key limitations, setting the stage for time and range. So what is CGM? It is a wearable device. It measures the interstitial fluid glucose over 24 hours, provide us with the real trends. And as you see, it consists of a sensor, a transmitter, and the reader or the phone app. So CGM reveals what hemoglobin A1C hides. It is proven to improve glycemic control, and it is associated, and the time and range is linked to the mortality and diabetes complications. This is one example of the AGP report. As you see, the time and range and the graph here, the glucose profile, it gives you a clearer picture of the diabetes control. So the gaps of hemoglobin A1C and the SMBG is addressed by the CGM by capturing the glucose trends and patterns, give you a continuous 24-hour real-time glucose data. It will identify the variability, detect and recognize hypoglycemia and hyperglycemia. It gives you have high accuracy, and it is associated with improved glycemic outcomes. For example, this patient, if we take the SMBG readings, 4 SMBG readings, however, when you put this patient on a CGM, you will see how we missed the hyperglycemia and the hypoglycemia events. This is the same. So CGM lets us see the hyperglycemia and the hypoglycemia events. For example, these two patients having the same hemoglobin A1C of 7%, however, they have different CGM patterns. As you see, the first patient have hyperglycemia and hypoglycemia excursions, giving him a hemoglobin A1C of 7. However, the second patient have well-controlled and good time and range. That's why his hemoglobin A1C is 7%. So what is time and range? Time and range represent the percentage of time a person glucose level remain within a defined target, which is 70 to 180 for general people with diabetes. It should be more than 70% of the time, which is equal to 17 hours per day, and it's measured by CGM. However, the time and range should be individualized according to the patient's condition, age, comorbidities, pregnancy status, And this year, the ADA guidelines added to the individualization of hemoglobin A1c the CGM matrix. So in general, as we said, the time and range for most people with diabetes is to be in time and range more than 70% of the time. However, in elderly and patients with comorbidities, it should be less, which is more than 50%. So individualization also is important. So the other CGM matrix, other than the time and range, is the time above range stage 1, time above range stage 2, and the targets is less than 25%, less than 5%. And the time below range stage 1, which is 70 to 54, should be less than 4%. The time below range stage 2, which should be less than 1%. And a very important matrix also the coefficient of variation, which measures the variability, the glucose variability, and should be less than 36%. So as you see, this patient CGM report, his hemoglobin A1c is around 6.7%. You will say that this patient is perfectly controlled. However, when we look at his CGM, he has a lot of hypoglycemias, 9%, or around 11%, the 9 and 3%, around 12% hypoglycemia. This is severe hypoglycemia. And the glucose variability is 50%. So though his hemoglobin A1c is 6.7, when you see the graph, the ambulatory glucose profile, you see how variable is the glucose. He's having hypoglycemias early morning from 3 to 6, and hypoglycemia in the evening also from 4 p.m. to 9 p.m. These are the targets for different population. For example, as we said, it's individualized for older high-risk patients and for pregnant ladies. So what are the factors that support the use of time and range as an outcome measure? Because it correlates well with hemoglobin A1c, it is associated with diabetes complications, and because of the benefits of the other CGM metrics along with the time and range. By evidence, it said that the 10% increase in time and range will give you 0.8% reduction in A1c. So if you recall the 70% time and range, this is equal to 6.7 hemoglobin A1c. And as you increase the time and range by 10, you can decrease the hemoglobin A1c by 0.8%. So what about the time and range and its relation with the diabetes complications? Also, every 10% increase in the time and range will give us reduction in the different microvascular complications. When do we start CGM? The earlier the better, because in this study, the first study, they compare two groups. The first group, by starting CGM within the first year of diagnosis, the other group started the CGM after 2.5 years of diagnosis. The early CGM initiator showed sustained benefit. However, the late CGM initiator showed delayed and attenuated benefit in terms of reduction of hemoglobin A1c. In terms of complications also, time in range and time in tight range are inversely associated with the presence of microvascular complications and cerebral vascular disease in type 1 diabetes. Compared to SMBG users, CGM users has better A1c in type 1 diabetes. Also in type 2 diabetes, CGM users compared to SMBG users showed better hemoglobin A1c reduction. When we compare the hemoglobin A1c to the time and range, that the hemoglobin A1c will give you a single shot, snapshot. However, the time and range will give you, it's like a video, will give you the real-time glucose patterns, trends over the day. It will give you day-to-day insight. But still, there are some limitations in terms of time and range, technical issues with the CGM, alarms fatigue, data analysis difficulties in the healthcare with the healthcare providers, skin reactions and complications. Some people they don't like to wear devices. Acceptance by the providers. It will take time to open the report and read it in the clinic. These are the other CGM matrix, as we said, the time below range, the time above range, and the coefficient of variation. We come to the other CGM matrix, which are important in addition to the time and range, is the time below range and the glycemic variability. Time and range alone is insufficient. It correlates poorly with the hypoglycemia risk. Therefore, time below range and the coefficient of variation or the glycemic variability must be reported together because 75% of the hypoglycemia episodes are asymptomatic and sometimes we miss it from the hemoglobin A1c or the time and range. And by evidence, most of the hypoglycemia occurs in patients with hemoglobin A1c of less than 6%, but it also comes in patients with high hemoglobin A1c above 9%. So time and range should always be interpreted with time below range and coefficient of variation to better capture hypoglycemia. And the glycemic variability is associated with an increased risk of cardiovascular outcomes. As we see here, the hemoglobin A1c of this patient is 6.7. The time and range is 62 is acceptable. However, if we take in consideration only the hemoglobin A1c and the time and range only, we will miss the severe time below range and the glucose variability, the 50%, which is very high. Also for this example, for two patients with the same A1c, both have hemoglobin A1c of 8%. However, when we compare their CGMs, the first patient have high glycemic variabilities with severe hypoglycemia episode and hyperglycemic episodes. So by conclusion, what is your best tool to manage your patients with diabetes? What do you think? So is CGM just for the specialists? Because I believe a lot of my colleagues from the primary care is attending the conference today. What do you think? Is CGM only for the endocrinologist? No. Primary care providers, they are the ones who are seeing most of our patients of diabetes, larger numbers of the patients with diabetes. So it can be used in the primary care, and it's everywhere in the Gulf. They are using it in the primary care. Start simply. The support team is everywhere. The specialist is there, and to give the best care for your patient. So in conclusion, can time and range replace A1c? Time and range is increasingly regarded as a promising tool for improving diabetes management. Time and range provide insight into the quality of glucose control over a short period using CGM. Time and range offers valuable data on the variability of a glucose level throughout the day, which is not captured by hemoglobin A1c. However, while time and range offers important advantages, it should not be seen as a direct replacement of hemoglobin A1c. Time and range should be regarded as a complementary tool rather than a substitute, offering additional real-time information to guide therapy alongside the established role of hemoglobin A1c. Thank you.